Hi and welcome back to another video of Medic Notes. This video is on femoral hernia. Femoral hernia is relatively uncommon, but it is an important problem due to their high rate of strangulation. Because of their narrow neck, femoral hernia occurs when abdominal viscera or omentum passes through the femoral ring and into the potential space of the femoral canal. It accounts for 5% of abdominal hernias and are 3 times more common in women than men. Let's look at the brief anatomy of femoral canal. The femoral canal is an anatomical compartment, located in the anterior thigh. The contents of femoral canal are lymphatic vessels, lymph nodes, and some loose connective tissue. The superior border of the femoral canal is the femoral ring, which is covered by the femoral septum. In this picture, the purple area over here is the femoral canal. The main risk factors for developing a femoral hernia include female, pregnancy, higher incidence in multiparous women, raised intra-abdominal pressure such as during heavy lifting or chronic constipation, and increasing age. For clinical features, femoral hernias will commonly present as a small lump in the groin. Whilst a femoral hernia is usually asymptomatic, aside from the lump at presentation, due to the anatomy of the femoral canal, around 30% of femoral hernia cases will present as an emergency, either obstruction or strangulation. It is important to identify the exact location of the lump in the groin in order to decide which type of hernia is present. We can differentiate femoral hernia from inguinal hernia by looking at the location of the lump. Femoral hernia is found inferolateral to the pubic tubercle and medial to the femoral pulse, whereas inguinal hernia is superomedial to the pubic tubercle, and femoral hernia is usually irreducible due to the tightness of the femoral ring. The differential diagnoses for a lump in the groin include low presentation of inguinal hernia, femoral canal lipoma or lymph node, saphenous varix, or a femoral artery aneurysm. Athletic pubalgia occurs following a small tear in rectus sheath through which impingement of abdominal wall musculature can occur, most often in young athletes. For investigations, the diagnosis can be made clinically. Additional imaging is often required. Ultrasound scanning can demonstrate a femoral hernia, but these are operator dependent and a high index of suspicion is necessary. A CT abdomen pelvis scan will also demonstrate a femoral hernia, as well as delineate any differential diagnosis. This picture shows an ultrasound image demonstrating the typical right femoral hernia, emerging medial to a compressed femoral vein FV. Picture A was taken at rest and picture B was during Valsalva. For management, all femoral hernias should be managed surgically, ideally within 2 weeks of presentation, due to the high risk of strangulation. 2 different approaches can be taken with the femoral hernia surgical reduction. First is the low approach. The incision is made below the inguinal ligament, which has the advantage of not interfering with the inguinal structures, but does result in limited space for the removal of any compromised small bowel. Second is the high approach. The incision is made above the inguinal ligament. This is the preferred technique in an emergency intervention due to the easy access to compromised small bowel. The operation involves reducing the hernia and then narrowing the femoral ring with sutures medially between the pectineal and inguinal ligaments, or with a mesh plug. That's all for this video. Thank you.